A very good evening. I welcome you all to this webinar of the Chandigarh Ophthalmological Society, Acute Visual Loss. We are privileged to have amongst us some of the most eminent persons in this field. We have Dr. Gordon Plant from UK who's here, who's the master himself. Thank you, sir, for being here. And then we have Professor Vivek Lal, who heads the Neurology Services at the Advanced Eye Center, PGI Chandigarh. Professor Vishali Gupta, who heads the UVA and the Retinal Services at, again, the Advanced Eye Center, Chandigarh. And we have Dr. Shagun Korla with us, who is working as a senior resident or a fellow in the Pediatric Ophthalmology and Neuro-Ophthalmology Services. And of course, our moderator for this evening is Dr. Jaspreet Sukhija, who is also the president of the Chandigarh Ophthalmological Society. I will take a minute to introduce Dr. Jaspreet Sukhija, president of Chandigarh Ophthalmological Society, and then hand over the proceedings to him. So Dr. Jaspreet is a consultant in the Advanced Eye Center at the Postgraduate Institute of Medical Education and Research in Chandigarh. He's been here as a consultant for the last 15 years, and he has more than 100 publications in peer-reviewed index journals. He's also contributed chapters in books, including the famous one by Myron Yanov. He's been awarded with many, many honors and medals. He's the associate editor of the prestigious Acta Ophthalmologica. He was awarded the Orbit's International Gold Medal at the ESCRS, as well as the Best Video. Then he was honored with the Om Prakash Award in Pediatric Ophthalmology by the All India Ophthalmological Society in 2020. The Dr. Prem Chandra Award by the North Zone Ophthalmological Society, and the Professor Hanumantha Reddy Award, as well as the Gold Medal by the IIRSI. Dr. Jaspreet is invited as a speaker at various international and national pediatric ophthalmology and strabismology conferences. And he's also a reviewer for many international and national journals, as well as an evaluator for instruction courses at the All India Ophthalmological Society. I now hand over the proceedings to you, Dr. Jaspreet, to carry on with the rest of the webinar, please.
Thank you, Dr. Chintan, for those kind words of introduction. We indeed have a very eminent, speaker, and you can say a similar level of panelists. I mean, who are masters in the fields, and we would be having one case presentation as well. So obviously, I mean, masters really don't need an introduction, but yes, just to give a brief introduction of where they practice. I'll be just sharing my screen. Yes. So our panelists are Professor Vivek Lal and Professor Vishali Gupta, and our guest speaker is Dr. Gordon Plant. We have one case presentation by Dr. Shagun. So Dr. Gordon Plant trained in neurology at the National Hospital, Queen Square, and ophthalmology at Moorfields. And he had the opportunity to attend clinics with Bill Hoyt, I mean, a famous neuro-ophthalmologist. And Dr. Plant was appointed consultant to the NHNN, that's the National Hospital of Neurology and Neurosurgery, Guy St. Thomas in 1991. He has to his credit over 300 articles and a massive impact factor of H index of 70. He's trained a large number of fellows, shows interest in teaching, both from neurology and ophthalmology background. And as a training program director, he initiated the first medical ophthalmology training program in London. However, he has retired from clinical practice in 2020, but still remains active in research and teaching, and rather he's more sought after his retirement. So our panelists for today are Professor Vivek Lal. He is the professor and head of neurology at PGI Chandigarh and the former dean of Baba Farid University of Health Sciences, Punjab. Again, a doyen in his field. I mean, he's an invited chair and faculty teaching courses and scientific sessions in neuro-ophthalmology around the world, in Dubai and in Japan. He's a visiting guest faculty at the University of Oxford in 2016. He's also a teaching faculty for the Medical Ophthalmologic Society in 2016 and a visiting ophthalmologist. He has done a lot of work. He's a pioneer in his work on migraine, the ophthalmologic migraine, and probably he's published the largest series in headache in 2009. He has over 200 index publications with chapters in both national and international journals and books. Our next panelist is from the ophthalmology department. She's heading the Retinal and uvea services in PGI Chandigarh, and an accomplished vitreoretinal and uvea expert of international repute. She has a keen interest in inflammation and infections of the eye, and has a lot of original work on intraocular tuberculosis, fungal infections, and diabetic retinopathy, which you can read from her 268 publications in peer-reviewed journals. And Dr. Vishali has edited 6 books, contributed 68 book chapters, and has delivered more than 875 invited lectures. That speaks volumes of her. She's conducted 42 instruction courses at several international and national meetings. Currently, she is the secretary of the International Uveitis Study Group and president of Uveitis Society of India. And she has received name awards and also holds a US patent for multiplex PCR. Our next speaker who's going to be presenting a case is Dr. Shagun. She's a senior resident working in PGI Chandigarh, who's done her MS from Shimla, and she was a rank holder there. And she has presented papers in national and international conferences, and she has the index publication index journal as well. And thank you all for joining in. I would now request Dr. Gordon Plant to please start his talk.
Thank you very much, Jaspreet. I'm going to share my screen. So before I forget, I must say that it's wonderful, though not being with you, to be associated with Chandigarh. I have to say it's my favorite city in India, but it's the only one I've ever visited. And thanks to Dr. Lal, I've been there twice. I had a very, very brief visit to Hyderabad when I arrived without a visa. And all I can say is they're charming there, absolutely charming. They put me in the same seat on the same plane, and I went home again. But Chandigarh was always wonderful. So what I said I'd do here, I'm starting a little timer of my own. Here we go. And we're going to talk about acute visual failure, but we're going to limit this to, whoops, here we go. Acute visual failure, not subacute. So we're not going to talk about optic neuritis, and we're not going to talk about pure ophthalmic causes, no acute glaucoma. And we're not going to talk about transient visual loss, because honestly, that takes just as much time to go through. So that's my brief, which I've given myself. Thank you. And so these are cases that both ophthalmologists and neurologists will need to see and know about in the acute situation. So the first case is a middle-aged patient who presents having woken with total loss of the lower half of the visual field in one eye that morning. And here we have the first problem about diagnosing acute visual loss, is that we have an entity which is pseudo-acute. So we don't really know when this happened. We only know that the patient woke with the symptom. And it's also the case that many patients can lose vision in one eye gradually and not be aware of it. So something may happen, even something like visiting the optometrist and has the other eye covered. So we have the problem of pseudo abrupt onset. But fortunately with this patient, the eye examination has confirmed the acute onset. So here we have a branch retinal artery occlusion, and this appearance here I was taught to call cloudy swelling, which is it's a very interesting term because it goes back to histopathology. And in the 19th century, histopathologists looking at kidney or any bit identified cloudy swelling. And this is what we now call cytotoxic edema. And it was rather remarkable of the early ophthalmoscopists to realize that this was the same thing. And of course, the neurologists now are busy diagnosing cytotoxic edema in acute stroke using MRI, but ophthalmologists have been observing this for all this time. And I also use this slide to make people understand the cherry red spot, because if you show a complete central artery occlusion, they think the cherry red spot is the abnormal bit, where it's the only bit that's normal. It's the only bit that retains its normal color. So this, you can see my pointer, I presume. Here we have a hemi cherry red spot. And the other interesting feature here is that we also have a branch artery occlusion and also a calcific embolus. And this is very, very typical of calcific emboli. They are usually solitary and end up near the disc. This one has clearly moved on, causing a superior branch artery occlusion and a partial branch artery occlusion. If they're going to cause an occlusion, they're going to be a size that's not going to get much further than the disc itself. And they tend to be solitary, unlike cholesterol. So we've learned a lot just by looking at this fundus. And here's more cloudy swelling down here. And now, of course, with OCT, we can see the cloudy swelling directly. And here's, these are minor examples of it with branch artery occlusions. But this one here with a central retinal artery occlusion, we can see this is cytotoxic edema involving the inner retina. So that's what we're looking at. And here's a cholesterol embolus. These, of course, are often multiple, so-called Hollenhorst plaques, and may not be associated with visual loss at all, and they tend to break up and move on. So they're often multiple and further away from the disc by the time you see them. So what about the management? Well, we need some medical expertise in the history taking. There is the problem of deciding whether it really was abrupt. But then once we've decided the diagnosis, then we really need to know what the vascular risk factors are for this patient. And the type of emboli may be helpful to us. And the management is combined medical and ophthalmic. In Moorfield's eye casualty, they still lower the intraocular pressure with ocular massage. I don't think this has an evidence base, and of course there are anecdotal reports of seeing the embolus move on and visual recovery, but this can occur spontaneously. But this is still practiced. There was a trial of thrombolysis in Europe with thrombolysis injecting into the ophthalmic artery, and this was negative, but they allowed 12 hours to recruitment. And we have never really established this as a treatment in the UK. And I find that a lot of patients with loss of vision in one eye do not report immediately. The average Londoner will, if he or she loses vision in one eye, will probably wait a day to see if it clears. And if it doesn't, he'll go to the optician. So it's relatively unusual for patients to walk in immediately when this happens. But I'd be interested to know what your experience is. So the management is basically vascular risk factors, etc. And we tend to send these patients down a TIA pathway through the stroke unit. This is another abrupt loss of vision, although she's woken with it again. A tiny blur patch just above fixation in the left eye. Now, this patient was referred to me as optic neuritis. The ophthalmologist had shown the patient an Amsler grid, and she had drawn her scotoma here, But because there was no distortion, he thought this couldn't be retinal, and thought it might be optic neuritis, and sent the patient along. Now, I don't blame him for having missed this. It's not very easy to see, but here is the abnormal bit of the retina corresponding to the scotoma, and here is the OCT. So I've been seeing these cases for well, 50 years, I suppose, now. And I've always called these partial branch retinal artery occlusions, or partial retinal artery occlusions. But it's all been rediscovered and got this handle here, PAMM, paracentral acute middle maculopathy. And I think possibly because patients are much more likely to notice something like this if it's near fixation. So that's where the association with maculopathy comes along. But you can see this. I've even seen it throughout the retina. So here we don't have the cloudy swelling. We have swelling involving the inner nuclear layer. And this is, of course, a border zone area between the blood supply to the inner and outer retina. We'll be talking about border zones a bit more later on. So these are vascular events. You can call them what you like, but I think the significance is not that different. Here's another scenario. A 30-year-old construction worker admitted to hospital following a crush injury at work, and about an hour after arrival in the A&E complains of sudden bilateral loss of vision. Now, oh, cotton wool. Sorry, can't spell English. Wool. So this is Percher retinopathy. And this is cloudy swelling again, but it's patchy. And this is often misdiagnosed as cotton wool spots, which is of course due to hold-up of axonal transport in the nerve fiber layer. This is proper cloudy swelling. And the reason it takes on this patchy appearance is because there is no occlusion of the arterioles, of the larger vessels. This occlusion is all at the capillary level, and here due to fat embolism. And you will all know that there is a capillary-free zone alongside all of the retinal blood vessels, because in angiogenesis, that region of the retina is oxygenated from the arteriole itself. So capillaries don't appear there, and that's why you get this this patchy appearance, because it's sparing these regions adjacent to the blood vessels themselves. A little while ago, I was at Arvo and saw someone showing some fundus pictures in malaria, in cerebral malaria, and it looks very much like this. Though I think there it's antigen-antibody complex deposition, and I explained this to them, and they got a nice paper in Brain out of it. Another patient waking with loss of vision in one eye, and he's lost the lower half of vision, like our other patient. But here we've got something different. Now, this is known as anterior ischemic optic neuropathy, and by definition, the optic disc must be swollen. That's why it's called anterior. It's prelaminar ischemia, and so we have swelling of the optic disc. That is has to be the case, otherwise we cannot call this anterior ischemic optic neuropathy. But probably the more important observation here is the other disc, the unaffected eye, because because not all of us have a matched pair of eyes, but most of us do. And this is a crowded hypermetropic disc. And that is the highly significant observation, assuming this was the same, because this disc appearance is the major risk factor for this type of anterior ischemic optic neuropathy. Now, this was most clearly defined by Soham Singh Hairy, who is not a stranger to Chandigarh, I know, in 1974, by which time he was in London. And this is the garden variety, and it was called non-arteritic to differentiate it from giant cell arteritis. Now, it's not entirely satisfactory to define a condition with a negative. So this was very important because, of course, with this condition, there is no treatment, and it's relatively benign, risk to the other eye, sure, but total blindness very rare in this condition. So it was defined in this negative way because the management is so different from the management of giant cell arteritis. But it's really important to remember that there are other causes of anterior ischemic optic neuropathy, and even some other arteritic causes in younger patients, for example, not GCA, but other forms of arteritis. However, it's important, we see this very commonly, and if there's any doubt about the diagnosis, it tends to be in the younger patient, where we can even have some difficulty distinguishing from optic neuritis. And of course, follow-up will do that. But in the acute situation, I always found fluorescent angiography to be most helpful because it will show the typical sectoral hypoperfusion of the optic disc, which you will always see. So here's an acute patient, and here's the same case in the chronic state. And this is the part of the disc that is hypoperfused on fluorescein. The rest of the disc is swollen, but will not infarct. And what we're left with is this telltale sign of sectoral infarction. This is extremely important, and it allows us to diagnose AION even years later. Sometimes people turn up having just noticed this, or an optician notices the disc is abnormal. And if you see sectoral atrophy like this, then this is absolutely typical of AION. And we could even infer that this was a disc without a cup, a disc at risk before this happened. And the visual field defects in anterior ischemic optic neuropathy are accordingly disc-related field defects. When it happens in both eyes, they're quite often symmetrical, like this, mirror symmetrical. We have typical nasal field defects here in both eyes. So they will always be disc-related. People get confused about why there is this obeying of the respecting of the horizontal meridian in anterior ischemic optic neuropathy, and they think it must be something to do with the blood supply, but actually it has the same. The origin is from the ganglion cell trajectories. So some years ago, I worked with Hugh Perry in Oxford, where they had a whole series of monkey retinas where horseradish peroxidase had been injected into the optic nerve just behind the eye. So this is the flat mount of the retina. Here's the fovea here. It's very thin, so you get a hole there. And this is where the optic disc was over here. And the horseradish peroxidase have been popped here into the dorsal part of the optic nerve, just a centimeter or so behind the globe. And you can see that all of the nerve fibers, all of the ganglion cells above the horizontal raphe send their fibers to the upper part of the optic disc, and all those below send their fibers to the lower part of the optic disc. So although these ganglion cells are adjacent, the axons in the optic nerve couldn't be further apart. So it's a different explanation from with branch retinal artery occlusion, because of course also the blood vessels don't cross this horizontal raphe. Over nasal to the optic disc, there is no raphe. To the optic disc. What we don't know is what the initiating event is. There seems to be great individual variation even in the number of posterior ciliary arteries, and this may explain some of the difference in the pattern of defects that we see in this condition. But what we don't know is what is the initiating event. The only thing we know is that this disc at risk, which may be associated with hypermetropia, but not necessarily, this crowded disc seems to be the major risk factor. There may be obstructive sleep apnea in some patients. Nocturnal hypotension has proven this is Sohan Singh Hari's idea. It's very difficult to prove this. All of the 24-hour blood pressure monitoring that we do is looking at hypertension, and everyone has has the lowest blood pressure of all in the middle of the night. So it's very hard to prove that this requires intervention. And I would say that it is as never as anything can be in medicine related to embolism, because of the circle of Zen, because of the anastomoses there, it's extremely difficult to think of one embolus to cause this. But I've seen it myself in one patient when I was a registrar with atrial myxoma, and there's a pathology on this as well. But the whole of the posterior ciliary circulation is stuffed full of tumor emboli in that situation. Whether corticosteroids should be used in treatment is controversial, something maybe people want to discuss, and we don't even really know whether we're doing anything useful by sending these patients down the TIA pathway, and what sort of secondary prevention they need. So we're quite good at diagnosing AO. We're not very good at managing it. Certainly not very good at preventing the involvement of the other eye. So here's an 85-year-old patient who has total loss of vision in one eye and a recent onset of headaches and scalp tenderness. So some have claimed that this may be an early illustration of giant cell arteritis, a blind harpist here with a very prominent superficial temporal artery from 1350 BC. I think if you believe that, you can believe anything. But here's the difference. This is nothing like our AION case. The disc is not only acutely swollen, it's also pale, and that's because there's gross involvement of the blood supply. And we can confirm this again with fluorescent angiography, where we see frequently we see gross involvement of choroidal filling, not just the sectoral filling that we see with the non-arteritic form. And it's not possible to emphasize too much the urgency of the situation in treating this condition. And one of the aspects of giant cell arteritis is that there is very rarely thrombosis involved, sometimes in the pathology specimen, we might see thrombosis, but it's quite unusual. And the occlusion of the lumen is due to the gross swelling of the vessel wall, particularly the intermal swelling, which you see here. And this is very rapidly reversible. And we know this from various situations. The ultrasound, which is an alternative to biopsy to diagnose this condition, the so-called halo sign on ultrasound, is due to edema in the vessel wall. And I think it disappears within 4 days of treatment with corticosteroids. Whereas a temporal artery biopsy, I mean, my personal record is a patient who had symptoms for 2 years, who'd been on steroids for 2 years for another condition and still had a positive biopsy. But the other observation is that the superficial temporal artery, which can be thickened and pulseless after a few days of steroids, the pulses return. And I did once repeat a fluorescein angiogram on a patient who had a totally blind eye. We repeated the fluorescein angiogram after a week of corticosteroids, and it was completely normal. So this aspect is rapidly reversible. So even if we can't do anything about the loss of vision that's occurred, this is how the acute treatment can prevent further damage. So there's never a reason to delay treatment if you suspect giant cell arteritis. And we can discuss corticosteroid sparing. When I was training, it wasn't considered that there was anything other than corticosteroids that we could use for these patients. The evidence was slim for methotrexate, azathioprine, and so on, and we tended just to try and get them off corticosteroids. We did use cyclophosphamide, mainly in patients who were corticosteroid intolerant because of corticosteroid psychosis. So I treated a few patients with cyclophosphamide. That was quite successful. And tocilizumab has now been shown also to be successful, and we can use that if patients relapse as they're coming off corticosteroids. We start them on tocilizumab now. But in the acute situation, we're still using corticosteroids. So some patients with GCA may have ocular ischemia, which can be simply ischemia of the optic disc itself, not leading to infarction, but leading to postural loss of vision. So I remember one patient who was a consultant psychiatrist about to retire, who was sent to me as amaurosis fugax from Moorfields, but he was having episodes of loss of vision in one eye that lasted for seconds only, and was always provoked by change in posture, by standing. And these patients with fluctuating vision, you can actually, you can salvage the vision in the affected eye. And we tend to admit them, put them to bed, put them on steroids, of course, and plasma expanders and heparin sometimes. Not sure whether that does any good, but certainly this is a reason for acute treatment to prevent loss of vision in that eye. And this can go further to ischemia of the whole globe. So we can have the ocular ischemic syndrome in GCA, or even of the whole orbit with involvement of the extraocular muscles and so on. So, so here are some other manifestations of GCA. Of course, AION, but also posterior ischemic neuropathy. And I do tell my trainees that if they never diagnose posterior ischemic optic neuropathy, they might be wrong a couple of times in their career. It's much more likely to be something else, except in this situation, giant cell arteritis. The other clinical presentation is isolated choroidal ischemia, which is really also reversible. They often have very impaired color vision, and they may have quite unusual symptoms related to this. Of course, fluorescein angiography gives you the answer, and this is often, as I say, reversible loss of vision. So we talked about the ocular ischemic syndrome, transient visual loss, and don't forget transient diplopia in the elderly, and also that the young can present with a very similar syndrome if they have vasculitis. And we've certainly, one of the reasons for continuing with temporal artery biopsy is that we have diagnosed PAN and other forms of vasculitis on the temporal artery biopsy. So here's a 50-year-old man who's had spinal surgery, 7-hour operation in the prone position. And when he recovers from the anesthetic, he complains of total loss of vision in one eye, partial in the other. Fundus examination is normal. And this is the other situation in which we're permitted to make a diagnosis of posterior ischemic optic neuropathy. And these are the two most important causes of this, GCA and systemic hypotension, especially perioperative. And these effects of hypotension depend upon the distribution of the border zones in vascular supply, which we'll talk about a bit more later. And but this is extremely rare, but of course it's very important because it has medico-legal consequences and so on. And the cases are always, of course, very distressing, even for the surgeons. So it seems to be associated with loss of blood and hypertension, but many of the patients have no vascular risk factors, and it's even been seen in children. So here's a few, one particular study came up with these risk factors. So we think it's hypoperfusion, but can also occur on the venous side. We saw a case recently which was a patient who'd had robotic surgery for bladder cancer in the Trendelenburg position. And these patients, well, it appears that children can do this, so they probably get some experience at the fun fair. This is what the patients look like when after they've had these procedures. They look like they've done a few rounds with Muhammad Ali. But the reason we reported this patient is because we were able to make the diagnosis on an acute MRI. Because we were able to show that there was restricted diffusion in the optic nerve. And the reason this is important is because, of course, the ophthalmologist can see nothing in the eye itself. The surgeons and family are all very upset. They want to know what's going on. There's nothing to be done, but at least it's a way of making this diagnosis in the acute situation. So here's a patient with a sudden onset headache followed by rapidly evolving ophthalmoplegia and blindness. Pituitary apoplexy. So I'm a bit of a purist with this diagnosis. We have seen many patients with hemorrhage within a pituitary tumor, sometimes seen quite incidentally. They're being investigated for visual loss, and there's been no acute event, but there's hemorrhage in the tumor. What I've always referred to as pituitary apoplexy presents like a subarachnoid hemorrhage. And indeed, the CSF findings, if someone looks, are quite remarkable, with xanthochromia and often a cellular reaction, and may get misdiagnosed as meningitis. But there is often a bitemporal hemianopia, which of course may be pre-existing, may be acute. But the main reason that it can be a fatal condition is because of hypopituitarism, the abrupt loss of pituitary function and acute adrenal failure. So there's some quite good summaries in the literature on extensive case series, and a few remarkable things. A large number of these are not known to have pituitary tumors, which I think is why there's sometimes a delay in diagnosis. But the abrupt loss of pituitary function is extremely important, and if it's not recognized, this may lead to the fatality. And when I was a registrar, I wrote up some cases with a stuttering presentation, which they had CSF examination, were thought to have meningitis. And we've also published some guidelines on management with Professor Wass from Oxford. So here we have a patient who's presented with sudden total loss of vision, and the acute eye team find no abnormality, normal pupil light reflexes, and diagnose functional visual loss. However, he's in atrial fibrillation, and this patient has bilateral occipital infarction. And if you see a patient who has abrupt total loss of vision with no other associated symptoms, this is most likely to be the cause, and it's one of the top of the basilar syndromes. Here's a different situation, a young man who's doing a backflip while exercising in judo training, and he develops neck pain. 4 hours later, same thing, sudden bilateral loss of vision. This is a vertebral artery dissection, and we used to diagnose this by asking for T2 weighted images of the neck all the way up to the skull base, and looking for the telltale sign of blood in the vessel wall. We get a bit more information from CT now, but this was a good way of diagnosing. If they present to ophthalmology, they will often have a Horner syndrome if it's carotid, but this is vertebral artery. Number 10, again, an elderly lady who's thought to be functional, because although she's complaining of visual loss, she can read 6/6 with either eye. This is a Goldman field for any of you who've never seen them, and it's rather special because it was actually this was carried out by the late Bill Hoyt, and what he was explaining to us was why we look for a vertical step in the visual field. You all know about glaucoma and nasal steps. Well, this is a vertical step, and this is also the most convincing evidence for the origin of macular sparing, because this patient has bilateral hemianopias with bilateral macular sparing. But it's not the same in the two hemifields, because of course as we go across the vertical meridian, we're going from one hemifield to the other, so it's extremely unlikely that this would be contiguous across the vertical meridian. And indeed, here Bill Hoyt has plotted the left and right eyes separately, but on the same chart, and here you can see the much greater degree of macular sparing in the right hemifield compared to the left. And so this patient also had bilateral occipital infarction, but with sparing of the occipital pole. And this is where we learn about how the visual field is represented on striate cortex, the over-representation, as it used to be called, of the macula. It's really it's that the relationship between eccentricity and distance in visual cortex is a power function. It's not a linear function. So a large amount of sparing at the occipital pole results in a tiny area of visual field being spared. And we also learn about border zones. Now, we mentioned these already in the retina. So border zones used to be called watershed. And this was an unfortunate mistranslation by Miller-Fisher. Well, not mistranslation, misunderstanding, because they had been described in the German literature, and they were described as being analogous to the Leicester felt, which was in agriculture. They were talking about the field that was furthest away from the water supply. So if the water supply was inadequate, these fields were more vulnerable. Now, this is also, and this is a border zone. A watershed is if you're standing somewhere in the middle of the US and a drop of rain on this side goes to the Atlantic and on this side goes to the Pacific, that's a watershed. That's not what this is. This is the Leicester felt. It's a border zone. And this is less vulnerable because it has a dual supply. In the case of the occipital pole, there's a supply from middle cerebral as well as the posterior cerebral artery. So if you occlude the posterior cerebral artery, it has a dual supply. Where they become more vulnerable is in acute vascular failure, where both supplies are affected. For example, cardiac arrest and acute hypotension. So this is where this region becomes more vulnerable. So we can see cases where this is also more affected. But it's not only stroke. This was a patient who was also thought to be functional, who was a post-head injury patient. And he was thought to be functional because not only did he have normal visual acuity with his little preserved hemianopic field here, but he had normal VEPs. And this is a lesson because the VEP is generated entirely from the central few degrees of the visual field. And it can happen in reverse. So this patient was referred to me because she had difficulty reading and recognizing faces, and she'd had 4 fluorescent angiograms over a 2-year period looking for the maculopathy because she said that the faces were distorted. But this was with binocular viewing, and it was exactly the same with either eye viewing. And she had normal fields, but she had a very small homonymous scotoma just to the right of fixation, which I was able to pick up with a tangent field at a 4.5 meter viewing distance. So this is the reverse situation, and these probably for the same reason, because this is a border zone in supply. This is the reverse of macular sparing, and something that is often difficult to diagnose, these small paracentral homonymous scotomas. Right, well, I've taken you on a Cook's tour of visual loss, and would be very interested to know if you have any questions or comments.
Yeah. Thank you, Dr. Plant. That was a wonderful illustration of cases. Yes, there would be a number of questions. Yes, Professor Vivek Lal, sir, your comments?
I think it was outstanding. I mean, it's deja vu. I've listened to him in Chandigarh twice, and he's the same plant. I mean, it's phenomenal to see him speak with so much of clarity and lucidity. So thank you so much for telling us and reminding us that we still are nowhere in a complete, we're nowhere in comprehending acute visual loss as well as you do. Now, the beauty about Professor Plant, I don't know whether you know it or not, he once told me is he's a qualified neurologist. That's right, Professor Plant? Yeah?
Yeah, yes, I'm only a qualified neurologist.
Yeah, but he knows more ophthalmology than most ophthalmologists. So I feel very happy saying that.
in a limited area.
In a limited area.
Don't get me on the cornea.
Well, when you're on the nano's web, you have to see his comments. You have to see there is so much to learn from his comments. And I think this was an outstanding presentation of basically vascular involvement of the eye. And I can tell you, we've seen branch retinal artery occlusions. We see so many. We diagnose them with our ophthalmology colleagues who have given us unstinted help. I mean, neuro-ophthalmology in Chandigarh is flourishing because of the unstinted help with which the ophthalmology colleagues, they are the ones who have got all the cutting edge instruments. We are their poor cousins. We are their poor cousins. If at all they let me call myself as their distant poor cousin, it's okay with me. It's okay. But they have never ever, relented in helping us. They've always been there for us. And that is what has made our series of acute visual loss almost as interesting as yours. We get to see a lot of vascular,
yes, fascinating stuff. And what you say is so true. You know that this was realized in Queen Square when the first hospital opened when the hospital first opened in 1860. There were only 4 consultants on the staff. One of them was an ophthalmologist, Lawrence, and sadly he died a few years later. The other one was a general surgeon. There's no evidence that he ever went near the hospital. And then two physicians, one of whom was Brown Sicard, which got the hospital onto the great start. But within they had 2 ophthalmologists on the staff 20 years later, and also Hewlins Jackson, and who pioneered the use of the ophthalmoscope. They knew they called it optic neuritis, but they knew all about papillary tumors. That's why they were so interested, and they were ahead of the ophthalmologists in 1850, certainly. So I think that link between ophthalmology and neurology must never be lost. And we've always had wonderful ophthalmologists working at Queen Square.
Yes, Dr.
Chandigarh.
Ma'am,
And Chandigarh.
your comment on the wonderful retina cases. I mean, Dr. Plant was mentioning in his first case, the CRAO, I mean, thrombolysis and all, and he said, what is your opinion about it here? So, ma'am, any comments on the cases or the type of cases in CRAO?
Absolutely brilliant, Dr. Gordon. And it's very encouraging to see a neurologist talking about PAM, I was wow, PAM.
Well, a couple of years ago, I published a series, I think it was 20 patients, all retinal disorders referred to me from ophthalmology.
Absolutely. And
so it's become quite a problem. And even after OCT.
You show beautiful emboli. And of course, OCT helps us in picking up those areas of ischemia. And now we have NGO-OCT, which beautifully shows which layer is knocked off. I just wanted to ask you, do you see Sussex syndrome in you?
Oh, yes. Yes, absolutely. Yes. We've seen several cases over the years. and I find the diagnosis is quite easy to make in the retina. I don't know if you agree. One of our trainees tried to publish it as the lightsaber. What's it called in Star Wars? They have that
the spindle which you see on fluorescein.
Yeah, there's a thing in Star Wars that when they have the light. He tried, because what you see is a long segment of the arterial is leaking,
Yes.
and not only where the infarction is, also elsewhere, the asymptomatic eye. And I think it's absolutely diagnostic as far as I know. I've never seen anything like it in any other situation.
It's very classic. Once you see it, you just don't miss it. But your presentation was very enjoyable. It was really fun.
I have a question, Professor Plant. Have you seen a tumor besides the myxoma present with acute visual loss?
Do you mean with ischemic visual loss?
Yeah.
Well, yes, with necrosis.
We see cervix do that. We have seen a patient of CS cervix who presented with acute visual loss and who eventually didn't make it, and who on autopsy turned out to be having occlusion of the ophthalmic artery.
Oh, what was the tumor?
CS cervix, cervical cancer.
Cervix, yes. Well, I'll tell you the classic for that is the glioblastoma affecting the optic nerve, but it's usually not very acute. What happens is they get something that looks like a vein occlusion, and then a little while later they get an arterial occlusion. Bill Hoyt first described that, actually. So these malignant gliomas of the optic nerve in middle-aged people are always dead within a year of diagnosis. But I've also seen it in other types of tumor where there's necrosis in the tumor, so they get a sudden swelling and a vascular occlusion as a result of that. Or with radiotherapy, there was one I saw had necrosis with radiotherapy leading to a vascular occlusion.
Finally, one more question, sir, if I'm allowed to ask. Can I ask Professor Plant another question, just please? Sir, have you seen any Saturday night visual loss? I mean, referring to retinal artery occlusion in alcoholics. I mean, we read so much about them in undergraduation.
You mean from pressure on the globe?
Yes.
No, sadly, it does happen. Of course, the usual Saturday night paralysis is over the arm of a chair, so they get a radial nerve palsy.
Yes.
But we have seen, but of course, it can happen even on the ITU sometimes, or patients with with facial palsies where they've been too enthusiastic in padding the eye. Yeah, it certainly can happen.
So you've seen it. It does occur.
Yes. Well, actually, it was in the older literature on spinal surgery, because it always used to be the argument with these operations where there was pressure on the globe, and they used to have this kind of horseshoe rest thing, and the patient used to be completely under the drapes.
Yes.
And then you'd find at the end of the operation that they'd moved and there was pressure on the globe, and they had a blind eye from that. But they solved that problem by making sure that the anaesthetist could always see the patient's head. Seems very obvious, doesn't it? But it took a few blind patients for them to realize they had to be able to see the patient's head throughout the procedure. And then it was realized there was something else going on. Despite that, they were still getting these cases waking up with loss of vision. So yes, pressure on the globe is certainly, I don't know if the ophthalmologists have any cautionary tales on that.
Retrobulbar anesthesia, the block. There used to be a device to put a pressure on the eye after you have given the block. that itself could cause,
Oh, really?
yeah.
Yes.
That
the other thing that we're seeing now is the injections of filler. So what happens is if you inject the filler into a small artery, it will go retrograde until it reaches a bifurcation, and then it will go anterograde down the other artery. And if that happens to be, getting into the ophthalmic artery, so there have been quite a few cases there as well.
Coming to one of the questions on CRAO, I mean, is there a role of antiplatelet therapy and statins in patients with CRAO?
Oh yes, I mean, if the central retinal artery occlusion is due to atherosclerotic disease rather than embolism and so on, then that will be the management indeed. The difficulty is AON. There doesn't seem to be any evidence that these things help, and I think that AON has a different. It doesn't have the same sort of etiology, because it's just this morphology of the disc that's the risk factor. Of course, you see patients with chronic, I say that other situations, chronic renal failure, hypertension, and so on. And of course, these diabetic cases, which are very interesting as well, some of which have disc swelling without loss of vision. But I think that the classic AON, we don't really know what causes it.
One basic question which maybe even the residents or the general ophthalmologists would be asking, how do we differentiate between a retinal cause versus a neurological cause? When your patient presents with acute loss of vision and you can't find anything in the fundus.
Well, in what situation would the retina look completely normal if it was it was a retinal cause?
And completely normal. You know, you look at the pupillary reactions, the pupil, relative afferent pupillary defect,
will be no different.
RAPD, if you're seeing, that's more, yeah.
The RAPD will be
So
the same, whether it's retinal or optic nerve. It just depends on the difference with the difference in the pupil. In the pupil response between retinal and optic nerve disease, it just depends on the fact that in the retina, usually it's a discrete lesion, and there's plenty of other retina there, and you can't detect the difference clinically. Of course, if you shine the light in the blind area of the retina, there will be a defect. Whereas with optic nerve inflammation and compression and so on, there's so many of the pupil light reflex fibers, these intrinsically photosensitive retinal ganglion cells, so many of the fibers are affected that there will always be. So it's just a question of how discrete it is in the retina compared to in the optic nerve. That's why we see the difference. If you've got a blind eye from retinal disease, you'll have no pupil light reflex. But
but if you have a blind eye due to retinal disease, most of the times you would not miss that retinal disease.
No, quite. I see what you mean. So you're quite right. So the more subtle case is like the pan case I showed you. You're not going to get a RAP in that case as you would have done if it was optic neuritis. I take your point.
So would color vision testing help in such cases?
Again, it depends on whether the macula is affected.
Yeah.
So it's a similar argument as with, so if you have good visual acuity and a pupil light reflex abnormality and color vision abnormality, that's much more likely to be optic nerve. But if you have preserved acuity, if you have poor acuity with macular disease, you're also going to lose some color vision. But that particular combination of good acuity, poor color vision, light reflex, much more likely to be optic nerve.
you showed a number of Goldman visual fields. So what is your take on whether we do the Goldman or we do the 30-2?
I think the Goldman is very helpful in neuro-ophthalmology, particularly where we may be more interested in more peripheral vision. But the Humphrey is so much universally used now, and it's very good for monitoring and so on. So we tend to use the Goldman for specific cases rather than routinely.
And the other question which comes to my mind is in a patient with bilateral acute visual loss. Clinically, how would you, you can say, if he comes in the acute stage, what is the way to differentiate whether you're dealing with a occipital infarct versus a bilateral PION?
Ah, well, that's the pupil.
It's a bilateral PION, so...
Bilateral PION, you will lose your pupil-like reflex. It will be normal with occipital. Of course, there's always some way to qualify these statements. In fact, the pupil-like reflex is not completely normal with occipital lesions. It is affected, but not in a way that we can detect clinically.
That's your favorite topic.
One of them.
Yeah, one of them.
The other thing
is something very personal about Professor Plant. All his pupillary images are made, animations are made by his daughter who works for the BBC. Am I right, sir?
You're giving away my secrets.
No, but you showed them beautifully in the previous World Congress. You know, you mentioned that. Yeah. Yeah.
The other thing you mentioned was having a patient of AION and a disc edema. And so sometimes it just happens that the visual loss simulates optic neuritis. So how would you differentiate between seeing you can say, having an ocular examination and trying to see where it fits in?
Yeah, this comes up occasionally, and it's usually a patient of an intermediate age, say 35 or 40 or something like that. We may say getting on a bit for MS optic neuritis, although not NMO optic neuritis, which occurs throughout the age range, but getting on a bit for MS optic neuritis and a bit young for an anterior ischemic optic neuropathy. If you have a really clear-cut disc-related field defect, like an altitudinal or something like that, then that's not very likely to be optic neuritis, but it still can be. So I think that the other thing, though, is that if you have involvement of the optic nerve in the orbit, then in optic neuritis, which you will have if the disc is swollen, then this will almost always be painful. The exception is the very, very anterior optic neuritis, which we call neuroretinitis. Not a very good term, but that's a sort of prelaminar. But if it's involving the optic nerve in the orbit, then this will be painful, whereas AION will not be painful. So that's one couple of distinguishing things. But every now and again, as I mentioned in the talk, I really can't make up my mind, and the fluorescein will help. Because if it's optic neuritis, the whole disc leaks. And if it's AION, you've got that typical sectoral hypoperfusion, which is diagnostic. But I think probably I wouldn't have done that more than once a year.
When would you look for like buried drusen in such cases?
Well, I think I'm not sure how it affects the management. I think it seems clear that if you have drusen, you may be more vulnerable to AION, but then actually it's the same optic disc that gets both. So we have the disc at risk for AION. Also, the drusen optic disc also has no cup. So whether the drusen make a difference to the risk, I rather suspect that they may not, because one of the other questions is, why is it so rare to get AION in the same eye? And one idea is that, well, you've no longer got a crowded disc because you've lost 25% of the nerve fibers. And the thing about optic disc drusen is that they are a cause of optic neuropathy, and the nerve fiber layer, although the disc is elevated, the nerve fiber layer is usually thin. So maybe that may also protect them from getting AION. So yes, we always look for drusen in anyone who has a crowded disc, but I'm not sure how it affects our thinking or management if we find them.
I think sometimes the drusen on the disc could be confused with the optic nerve edema. So, you know, especially when it's not Dr. Gordon who's examining them and young people, so they confuse the presence of the optic nerve head drusen with any disc edema. And the key to that is the lumpy, bumpy appearance of the optic nerve head, and just get an autofluorescence image. And when you see the autofluorescence, you will see them as hyper reflectance dots. So that is the way you can differentiate. It's like one of the differential diagnoses of optic disc edema.
Yeah, yes, indeed. But it's important to remember that people who have optic disc drusen are not protected from getting brain tumors and other conditions. Drusen are very common. But exactly how they relate to this weird, to me still weird, syndrome of AION, I don't know. One of my teachers, Christopher Earle, and I first took over as consultant from him at the Holborn branch of Moorfields, which closed when I was the registrar. I took over his clinic as a locum. And he said to me, after thinking about AION for 40 years, he decided it was ophthalmological. I think by that he meant that it's primarily it's in the eye. I mean, the ball in the eye and in the peculiarities of the circulation in the eye. And I think he was right, but we still aren't really any further forward, despite all that Sohan Singh-Hari has done.
One more
And another thing, if I might add, a quick comment, neuroretinitis. When you see neuroretinitis, the conditions like cat scratch disease, sometimes toxoplasmosis, syphilis, they also have to be kept in the mind, and don't be in a hurry just to give steroids, because those infections could present as neuroretinitis as the primary manifestations.
Absolutely, and we now know from the OCT that this is because this is subretinal fluid, which is tracking towards the disc. So you don't see the star.
You don't treat the star. Yeah.
You don't see the star until later on. And so when you see the patient acutely, they just have a swollen disc. The OCT will show you the fluid there already. And Andy Lee, who's very keen on treating the Borrelia cases, he advocates OCT in all acute optic devices with a swollen disc, so that you can diagnose neuroretinitis straight away. Of course, there's some discussion over whether the antibiotic treatment is actually doing anything in those cases.
Yeah, but sometimes you do end up giving tetracyclines, and you know, there is a controversy, but still many of us are very happy doing something for the patient, and we end up giving doxycycline.
I don't like the term neuroretinitis. I mean, it's introduced by Labour.
Yes.
and sometimes called labor stellate neuroretinitis. And labor describes so many things. We don't have to give him that one, because I think that it's just a very anterior optic neuritis producing subretinal fluid, whereas optic nerve, the transudate from the edema, it just goes into the subarachnoid space around the optic nerve, whereas if it's anterior, it goes under the retina. And I think that's really what we should be looking at. We should be looking at the epitopes that are in the prelaminar optic nerve to cause this very anterior optic neuritis. I haven't got to that bit in your chapter yet, Vivek. I'll have to get back to that. And the problem is, of course, that anterior ischemic optic neuropathy and papilledema can both give rise to a macular star if they generate enough fluid to track along and end up in Henle's layer and cause the macular star. And I must say that I've seen, rather like posterior ischemic optic neuropathy, I rather regret that some of our ophthalmologic colleagues have heard of neuroretinitis, because certainly I've seen a few cases of children with chronic papilledema misdiagnosed as neuroretinitis because they had a macular star. The one difference is quite often with those conditions, it's only a hemistar. You just get the star on the nasal side of the macula, but that's just because there's less fluid, I think. So I didn't get a retinitis at all. I think that was a mistake.
There is no retinitis, but you may see some cells in the vitreous.
Oh,
so
yes.
If you see some cells, that would be a very important indicator in differentiating the two.
Absolutely. And that to me would go along with this concept of it being a prelaminar optic neuritis. I mean, you can get a few cells even with multiple sclerosis.
In the multiple sclerosis, if we look in the periphery, you may see some snowballs in the extreme periphery down, or vasculitis on fluorescein angiography. So one must order a wide field fluorescein angiography of 200 degree to look in the periphery, because they are very important clues for MS.
Oh, well, absolutely. And pars planitis, of course, is quite commonly associated. And indeed, if you follow up patients with intermediate uveitis and pars planitis, some of them will develop MS. But personally, I think it's a coexisting different disease.
Maybe.
Yeah, I think it's a coexisting disease, but I think it's not the same as MS. But what we see in MS, you're absolutely right, is that venulitis, the leaking blood vessels, which have been shown in histology, and we now know that from 10 Tesla MRI, whatever they're up to, we know that every MS lesion in the brain has a venule. It's around a venule.
Dawson said that a long time ago.
That's right. Well, Dawson said that Dawson's fingers, the venules coming out from the ventricles, and that's the origin of that distribution and configuration of the periventricular lesions. But actually, every single MS lesion in the brain all has a venule in the middle of it.
Yes, it does.
They either look like tadpoles. Do you call them tadpoles?
Not so far. They don't look like tadpoles, actually. They're pretty asymmetrical. I mean, they're not tadpole-like, you know.
No. These are not the periventricular ones.
Okay.
So, some of the others, they look like tadpoles, like this.
Yeah. That's right. Yeah. So
that's a venule.
Okay. Yeah. That's right. Yeah. But they're perivenular. That's the hallmark.
Yeah, it is. Yes, and that's what has been, as you say, Professor Gupta, that's what's been shown in the retina, both clinically and yeah. So I think that's the thing that's part of MS. I think the pars planitis and intermediate uveitis is possibly just a related condition that occurs in the same individuals, because the risk of developing MS from if you have intermediate uveitis is quite low. The problem we have is that some of the severe cases are being treated with etanercepts now, the anti-TNF alpha, which was originally used in rheumatoid arthritis. And this actually provokes MS attacks. It provokes relapses, the anti-TNF alpha drugs. And so now before they treat the uveitis patients, they do an MRI scan to screen for MS. And of course, if they find it, it's asymptomatic, and they send it to us as I'm sure Vivek is seeing, like as many patients who have a scan for some other reason and have pre-symptomatic or asymptomatic MS, and we don't know what to do with these patients. But certainly, we have to do the screening, because otherwise they will have their first relapse very likely when you give them these drugs. So that's one of the other sides of that link between these uveitis cases and MS, is the risk of provoking attacks due to the treatment.
One question before we go on to the next talk is, when would you use steroids in AION?
Well, this all started when Professor Hayrie published his paper. Now, he had applied, it's all in his paper, this is in the public domain. He tried to get a grant to look at the effect of corticosteroids in AION 30 years ago and failed. But he did a study anyway, but it was not blinded, and he did the observations himself, and the patients were just asked whether they minded going on corticosteroids or not. They weren't, that was the way they were selected. So it wasn't a very good study. But at one time, well, still actually, it's the only treatment that's been shown in any sort of study to help. So what happened to me was patients would find this on the internet, and they would phone this number, and day or night, Professor Hayrie would reply. And so they'd come back to me saying that they needed to go on to corticosteroids. So I'd give them homeopathic steroids, you know. And then a few patients down the line, someone else would come back to me. I've spoken to Dr. Hayrie on the phone, and he says that not only you should be giving me steroids, but you're not giving high enough doses. And his protocol was 80 milligrams a day while the disc was swollen. So I don't know. I think that...
I think, Dr. Gordon, the problem...
Sorry? Oh, I think you've lost...
Yeah, no.
Did you freeze for a minute?
Yeah, I think the issue is, Dr. Gordon, we call it AION. We put in the word ischemia and neuritis in the same category. And we do understand that many times inflammation itself can induce ischemia. Like we see that in Behçet's and so many diseases, whenever there is inflammation, it may end up in ischemia. So to be very sure that AION does not have any component of inflammation, that is what we need before we say no steroids. You know?
I agree with you, but I would put, but as I said, I think that AION is this negatively defined entity.
Probably you need to change the name of the disease, Dr. Gordon. You should change.
So GCA is here, and AION is here, but in between the two, there's a lot of other conditions that do require corticosteroids.
Yes.
So I think you have to be very, very clear and about that the patient has the right risk factors for AION and so on. But I think that the evidence that corticosteroids are helpful in this garden variety, the classical AION, is not strong.
Not strong, yeah. But most of the times, it's not you, but majority of the people may not be very confident in saying that this is AION. So just lack of confidence, you might end up treating with steroids because there is nothing else to offer.
Oh, absolutely. And I've had some devastating cases, really unusual cases in young patients, both eyes involved. I've given them steroids because I've given them steroids and aspirin because I've got nothing else to offer.
And now we have a new drug injecting intravitreal brolucizumab, which is causing arterial occlusion. You don't know what is causing it, is the drug, antibodies, and what. But still, we are all ending up giving very heavy dose of steroids because that is something you do when you don't know what to do.
It's true, but it's a common enough condition. The problem is that the other treatment trial, of course, in AION was optic nerve sheath fenestration.
Yeah.
And this was started by Bob Surgut at the Wills, and nobody ever picked up on what he actually described. He didn't mention them in the talk, but there is a group of AION patients who have a progressive course, and it can be over 3 months. They have all the other typical features, but they have a progressive course over 3 months. It's rare, but I've seen it several times. I don't know if any of you have. And of course, you do many more things to exclude other problems, but that's what you end up with. And it was those cases that Bob Surgut suggested improved with sheath fenestration. Then the Americans went on to do a trial of optic nerve sheath fenestration, but not exclusively on the progressive cases because, of course, they're so rare. And they very quickly discovered that the cases who were having the fenestration were doing worse, and the trial was stopped and so on. But so nobody has really gone back to look at these progressive cases and see whether they might be different in some way. I don't know if anyone else has seen them.
Maybe Dr. Lal.
Progressive AION case?
No. I would.
They're not common. And they're the kind of case that gets to me from all over the country. They get, because it's going on for so long and the diagnosed AION is still getting worse. So I tend to get referred those cases from our 70 million population. So I think they are rare.
Whether you're looking at a chronic progressive cryon, can I say use that word phrase? It's a
if it's cryon, then it's inflammatory and will improve with steroids. This is from fluorescein angiography and all other criteria. It's an AION, but it's following a progressive course.
The only time I saw 2 cases where 2 patients have Takayasu's arteritis.
Oh, yes.
I saw 2 patients of Takayasu's arteritis who had progressive AION by your definition.
Yeah, yes, that's right. So that's about Takayasu's is of course the young lady GCA.
Yeah, young GCA. So I saw 2 patients and who underwent a vascular procedure, repair procedure.
Thank you so much for the wonderful discussion and nice presentation, Dr. Plant. We have a short case presentation by the senior resident, Dr. Shagun, and then we can have your comments on that.
Thank you, sir. I would like to thank Dr. Jaspreet and Chandigarh Ophthalmological Society for giving me the opportunity. A 34-year-old male resident of Chandigarh presented to us with complaint of pain around the right eye with diminution of vision in the right eye for 3 days. The complaint of pain, which was dull, constant, increased with the movements of the eye and was associated with diminution of vision for 3 days alongside, which was sudden and progressive. It was associated with headache on the right side of the forehead. It was dull, aching and constant. He had a history of nausea, but there was no history of any vomiting, type 2 diabetes mellitus, hypertension, tuberculosis or any contact with the tuberculosis patient, no history of fever, no history of similar episode or any other systemic illness in the past. One particular history which he gave was that he had a trauma to the right eye with some remote control, which was by his own child. After that, he started having this diminution of vision along with pain in the right eye. In personal history, there was nothing significant was there. On ocular examination, the visual acuity was finger counting 1 meter in the right eye. It was 6'9" in the left eye. The IOP was normal in both the eyes. Lids and adnexa was normal. The extraocular movements were full and free in both the eyes. In pupils, there was a right relative afferent pupillary defect in the right eye. The anterior segment in both the eyes were normal. In posterior segment, I'll be discussing in the subsequent photos. Color vision by the Ishihara chart showed that he could not read even the demo plate in the right eye and was normal in the left eye. Now this is the fundus picture, disc picture of the patient in the right eye. It is showing hyperemic disc with obliteration of the cup, with blurring of the disc margins are there. Alongside there is a slight tortuosity of the vessels with some fullness of the venules can be seen. Whereas the left eye was apparently normal. So just to summarize, he was a 34-year-old male with complaints of pain exaggerated during eye movements with diminution of vision in right eye for 3 days, which was sudden and progressive, associated with dull, aching, right-sided headache and nausea. On examination, his vision was in right eye was finger counting at 1 meter. The left eye was absolutely normal. The right eye showed disc edema with macula normal in both the eyes.
Yes, we can have a, can you stop sharing? Can you stop sharing screen? Yes. Dr. Plant, so your comments on this disc edema, a moderate disc edema.
Yes, it's a very interesting case. I could say something about the remote control injury.
Yeah. So yes, the typical thing you said was that the moment his son hit his the remote control on his head, on his eye, he said he lost vision. But when he presented, it was this.
Yeah. I remember a case of a chap who'd been hit in the eye with a football, and he had a hypotonic disc swelling, so the ophthalmologist thought. But he, to get disc swelling from hypotonia, you have to be down to somewhere like 8 millimeters of mercury or so, and he's got slightly lower pressure in that eye than the other eye, but it seems quite normal. And you shouldn't get, it should be like ordinary papilledema, you shouldn't get loss of vision with that. I did see a very interesting case of delayed hypotonia. Was a young man who, as a schoolboy, had stabbed himself in the eye with a fountain pen accidentally, and he thought no more of it, but he presented to Moorfields with blurry vision in that eye and had a swollen disc, and they thought he had optic neuritis. And when I looked at him, he had a functioning bleb. So he had a little defect in the sclera and a little functioning little collection there. And so clearly, and when you went back over the history, periodically you'd had problems with that eye. So it is possible to get this swelling from an injury, but it's also so often the case that something incidental happens. I was talking about the problem of deciding when loss of vision occurred, because something may happen to make people notice loss of vision that they're not aware of. And I would have thought that's more likely here, that he because he got poked in the eye, he then realized that there was something wrong. So the other question is, the other important feature of this, of course, is the pain, because this would suggest an optic neuritis, because he's got pain on eye movement and pain in the forehead and so on. This is not like any ischemic problem. It suggests that he's got an inflammation there, pain on eye movement. And one of the main distinguishing features of NMO optic neuritis is it's so often intracranial that it's much more likely to be painless. So optic neuritis in MS is more likely to have disc swelling and more likely to have pain, because it's more likely to involve the orbital portion of the optic nerve. Even if it's retrobulbar, it's not anterior enough to cause disc swelling, but there will usually be pain.
Yes,
so the pain that he's experiencing suggests that he's got a quality of the pain. The only thing is, with MS optic neuritis, of course, the pain is usually very mild. This seems a bit more severe than that to me. In fact, in MS often, they don't say, oh, I've got pain behind the eye that's worse when I move it. They say, oh, I have pain, but only when I move the eye, or only when I look in a particular direction. And I often ask patients, I don't know if you asked this chap, does he have pain at night?
Oh, so I haven't asked whether he had pain at night.
Because it's really unusual in MS optic neuritis to have pain at night. And if the patient is being woken by pain, then it's more likely to be due to something else. And then the other thing is, looking at this disc, it does look congested. It does look congested. So it has those features of, there's a bit of venous engorgement as well as the swelling. And so we would associate this more with something like a perineuritis picture, where the inflammation is actually in the optic nerve sheath, so giving more pain, and also a more congested looking disc.
I found that the venous engorgement was rather prominent.
Yes, I think it is. I mean, you can see it with garden variety optic neuritis, but it's quite prominent. And then of course, if you have perineuritis, you've got more congestion
Yes.
going on because of that. So, given the severity of the pain and the congestion of the disc, I would say that it's. I don't like this term atypical optic neuritis, because it depends where you are in the world, doesn't it?
Yeah.
And we had this. We suffered for decades from optic neuritis research and advice being dominated by North America, Europe, and Australasia, where MS is common, and I think possibly many people are blind in other parts of the world because of the optic neuritis treatment trial, saying that you don't need to give steroids. So I'd be worried here that we're dealing with one of these so-called, well, a non-MS optic neuritis, and then we have to go into the differential diagnosis of.
That's right. Yeah.
Dr. Gordon, when you see perineuritis, how common it is due to sarcoidosis in your practice?
Oh, well, it's common in this country. Mm-hmm. We see it more in the African Caribbean population, but it is common to here. Yes, we see a lot of sarcoid, my very good colleague Desmond Kidd, he was my last senior registrar before they were abolished and replaced by consultants. Now well, I didn't know why I retired, but so that happened in the year I was appointed. They got rid of senior registrars, and I've been a senior registrar ever since. I carried on doing the same work I did as senior registrar. So yeah, so he wrote up all of our sarcoid optic neuropathy cases and has written extensively on neurosarcoid. Yeah, we see a lot of that.
So
we'd expect to see a few cells. We'd expect to see a few cells in the vitreous if that was the case.
Yeah.
There were no cells, were there?
No, sir. No, sir. No cells.
No.
Dr. Plant, what needs to be investigated? I mean,
well, I think what would be most helpful here would be the MRI. I don't think we can learn a lot from OCT and more ophthalmic investigations, but in a case like this, where I'm suspecting some unusual inflammatory process that might need urgent treatment and other investigation, I would start with an MRI orbits, making sure that the patient was given contrast and had good fat-sat views and so on. But if you did you can do some blood tests, of course. You could do some blood tests, ESR and things like that, chest X-ray. But in terms of deciding exactly what's going on behind that optic disc, I would want to look at the MRI.
We ordered a blood for NMO in cases, or no? It looks like quite typical.
It could be NMO. Yes, I mean it's as I say, it's in that differential of non-MS optic neuritis, but that's not my results not come back for ages.
I have a question for all you neuro-ophthalmologists. Would you wait for the MRI to start corticosteroids, or would you just give it anyway in case you cannot get MRI in emergency?
You have to persuade your radiologist that this is an acute situation.
Okay.
And the other problem is that if you start giving steroids and then they have the MRI later, you may miss the boat.
You missed the boat. That's true.
Yeah. So I mean, if I have an aphorism that if giving corticosteroids, which turn out not to be needed, is a minor misdemeanor, but not giving corticosteroids to a case of optic neuritis that's going to finish up blind is a major misdemeanor, a major felony. Can't remember my own quote now. So minor misdemeanor if you give steroids to someone who turns out to have MS, but a major felony if you don't give steroids to someone who turns out to have NMO or cryon or a perineuritis. So I have persuaded, because we've worked so closely with them. You know, all throughout my career, I did 3 hours of neuroradiology every week. I did a 1 hour neuroradiology session at each of my 3 hospitals. And it's so important. I mean, I feel so, I don't know how it is for you guys, but I felt so sorry. My colleagues in Australia, where all of the radiology is farmed out to private units around the city. They don't have this close relationship that we have with our neuroradiologists, and we learn from each other, and they've learned from us how important this is. So I would be able, I hope my colleagues still could persuade our radiologists to do this straight away.
We do it. That's a very relevant question. I mean, if you don't have neuroradiologists who are with you, then you have lost your right arm if you're a neuro-ophthalmologist, and then you will never be a good neuro-ophthalmologist, you know.
Absolutely.
All our neuroradiology is done in-house by us, and we have got specific neuroradiologists who concentrate on orbital imaging. So we have very fat sat images. We got very good fat sat images. And question of, and most of our neuroradiology in relation to visual loss, because that's an emergency, is with us in 24 to 48 hours, max 48 hours.
That should be the case, but you will only get that where you have that kind of understanding and relationship.
Yeah, we are lucky. We do. We are lucky. That's right. And understanding is the key word. We are lucky with our ophthalmologists and radiologists. We're very lucky on that front.
And I remember one of the things that struck me with Bill Hoyt was he was always in radiology. He was always down there. I've forgotten the name of the particular senior guy there that he had worked with over decades, but and he was so interested in anatomy, and to me everything starts with anatomy, and that's what radiology is. So I think that you have to have that sort of relationship. So we're about to find out whether you did a scan or not on this patient.
Yeah.
So go on.
I mean, if you want to show me anything else before the scan, then do so.
So we did the visual fields as well as the OCT of the fiber layer and the ganglion cell layer.
Dr. Plant, the OCT of the left eye is showing the loss of the ganglion cells.
Oh, if he's already got loss, that means there's...
Next, left eye.
That's interesting. So from onset of symptoms, what's the time interval between onset of symptoms and this OCT?
So 5 days.
5 days, yeah. Well, we did have one. I can remember one one of the most severe optic neuritis cases I've ever seen was bilateral, and presumably due to some systemic immune response. And his ganglion cell there had gone while his disc was still swollen, and he was treated acutely with high doses of corticosteroid. He made no recovery whatsoever, ended up totally blind. So I think that's not a good sign. But it makes us wonder. So I think this could happen with an acute optic neuritis as quickly as that, and I can only say that because I've seen it. But it also suggests that this has been going on for longer.
So this is the left eye actually, which showed the thinning. The right eye which had a scleroderma, it was showing normal thickness, but the left...
Oh, sorry, I beg your pardon. I'm getting my left and right. Okay, so he's got some previous problem with the other eye. Didn't look it on the optic disc though, did it, in the other eye? Is the nerve fiber layer thin as well?
Yes, the nerve fiber layer was also thin in the left eye.
Opposite eye.
Right, okay.
Can you show this picture again, please? Because I don't... The left eye. It doesn't look pale to me.
No.
Retina person.
No, it's, well, of course, there might be something, there might be some, I think the temporal border might be a bit sharp, but it's so dark.
Also, this was just a peripapillary atrophy with some hyperpigmentation in the temporal area. Otherwise, the disc was normal.
Well, of course, if he's had an asymptomatic problem in the other eye, that's the OCT really is telling us something.
Yes.
But and of course we would see that more with MS on the whole, provided we don't have any other history like that he had a bang on the head or something that might have caused an optic neuropathy on the other side.
This loss, Dr. Plant, the loss which occurs, you can say, is it a continuous process or it occurs only when the attacks happen?
In MS?
Yeah.
Well, in MS there is a continuous loss in most cases, but it's only slightly higher than the usual attrition rate of nerve fiber layer and ganglion cells. But what happens is every time they have optic neuritis, they get a stepwise loss. But optic neuritis can occur asymptomatically in MS. And this was became clear, well, partly from clinical observation, because as Professor Lau will remember, in the pre-MRI era, we used to examine patients presenting with a sixth nerve palsy for subclinical signs of MS, and one of those was optic atrophy, asymptomatic optic atrophy. So, and also some patients present with Uthoff symptom, having never had optic neuritis, a clinical set of optic neuritis. So it's still possible that he's had an asymptomatic optic neuritis in the other eye, and that would push us more towards MS. But I still don't think the other eye looks like is typical of MS.
Coming to that point, would you investigate all these patients with bloods and MRIs, those who present, I mean, such different presentations they have, patients with optic neuritis?
Well, it depends how worried about them I am. When there was no treatment for MS, we did have a policy of not ordering MRI scans in patients who had what we thought was extremely likely to be an MS optic neuritis without counseling them. Because, of course, from the point of view of health insurance and life insurance and other things, having a diagnosis of optic neuritis was very different from having a diagnosis of multiple sclerosis. And many of the patients, when everything was explained to them, that it might be normal, it might be abnormal, if it's abnormal you're more likely, etc., etc., then many of them would say they didn't want to have an MRI. But it's different now because we have more effective treatments for MS. But certainly someone presenting like him with all that pain, I would have done a scan on this patient at any time.
Yeah. So what did the scan show? Go ahead. Yeah.
This axial scan showed multiple well-defined plaques in bilateral frontoparietal region with some discrete and some confluent plaques. So.
Yeah, so wasn't that interesting? The OCT actually told us a lot there, and took us away from an unusual optic neuritis to more likely MS because of the other eye. Once we've got the left and the right sorted out.
Isn't bilaterality more common in atypical optic neuritis?
Yeah, but bilateral and simultaneous.
Yeah. Okay.
Bilateral and simultaneous. That there's been some previous asymptomatic. Well, or when we say asymptomatic, not enough to bring him to attention. When you queried him, did he make any comment about remembering anything happening to the other eye?
No, sir. He was absolutely saying that he had no complaints of the left eye. He was just worried about the right eye.
Yeah, no, that's very interesting.
And the visual field showed anything in the left eye? He did have a scotoma, no?
Central scotoma was there in the left eye.
Yeah. So
maybe he just learned to live with it.
Well, I think so. As I say, asymptomatic optic neuropathy is not unusual in MS. I would also say that it would be quite unlikely in NMO. Just as spinal cord lesions in NMO, I don't know about Professor Lau, but I've never seen an asymptomatic spinal cord lesion in NMO, where again, it's extremely common in MS.
I tend to agree. But That's right. I mean, they're very common. Certainly, they're far more common in MS than in NMO. That's for sure. That's for sure. Because NMO will have long segment lesions which tend to be symptomatic. Whereas in MS, you can have partial lesions which tend to be asymptomatic.
Yeah.
Wouldn't have the color vision being infected with the ganglion cell being infected in the left eye? Is color vision was absolutely normal?
Well, he's got enough. He's got enough vision there to do your tests, hasn't he? But he's got, I think, from the optic neuritis studies, I think you have to lose about 40% of your nerve fiber layer before you start to be able to detect defects using our clinical tests. I think there's a great deal of redundancy in the optic nerve because you've got cells involved with color and motion, got 1 million fibers there, and I think you can lose a lot of them and still see very well. I wouldn't expect him to have a normal VP in that left eye, and that was what we moved on to from when VEPs came in the 70s. We went on to looking for asymptomatic delayed VEP, and if you had a young patient with perfectly normal vision and a delayed VEP with a normal amplitude, that was almost diagnostic of MS, really.
Yes, it was. It still is. It still is, you know. Yeah, right. Yeah.
Just don't use it because
yeah,
looking at one nerve or two nerves, and we've got the whole of the brain and spinal cord we can look at now for asymptomatic lesions.
And the significant aspect of this MRI is there's also, you know, corpus callosum atrophy, which means that this illness has been around for quite some time.
Mm.
You know, besides, of course, having Dawson's fingers, as we just discussed, there's corpus callosum atrophy also.
Yeah, so the other thing is to ask about the other sometimes unrecognized symptoms of MS that we used to inquire about are, for example, Lhermitte's symptoms. So often people develop Lhermitte's symptom, which is due to a cervical cord lesion, and the only manifestation they have is that when they flex their neck, they get an electric shock feeling going down their spine and into their limbs. And usually when that happens and they're not known to have MS, they're just told that they have a trapped nerve and get some physio or nothing, and it tends to go away after a while. And another one is vertigo. So quite often patients with MS have an attack of vertigo, and this again is called vestibular neuritis. It recovers. So there's quite a few things you can ask patients. Did they ever have a period when their vision went dim when they exercised? Have they had Lhermitte's symptom? Have they had an episode of vertigo? These are all things that if you go into, you may find that does happen in the past and have been put down to other things. It's much easier with the MRI. We had to jump through hoops back in the old days.
Yes, yes.
But we had no treatment anyway, so it didn't matter.
The orbital one, the orbital MRI. Yeah. So what do you see?
So there was on post-contrast T1, there was mild diffuse perioptic enhancement in the intra or in the orbital segment of the right optic nerve, just involving the orbital segment of the optic nerve. By the left optic nerve, the radiologist said that it was normal as compared to the right eye. It's well appreciated. So
Can you call that perineuritis, Dr. Plant?
Sorry?
We were discussing about perineuritis in this case. I mean, earlier with the disc edema, with the venous congestion.
Yes, absolutely. Well, of course, you know about Occam's razor and Hickham's dictum. Have you come across those?
I've heard about them. I don't remember them.
So Occam, he was an English Franciscan monk, 12th century, and he came up with this this idea that if you're presented with a group of phenomena, always try to come up with one explanation. In actual fact, he said the smallest number. He's misquoted, actually. I'm correcting myself here. He didn't say one, but you should come up with the smallest number of explanations for a set of phenomena, and I think it's a reasonable rule. The Americans came up with Hickham's dictum was that a guy can have as many diseases as he pleases. So and you know, I was sufficiently worried about this optic neuritis to make me wonder whether perhaps this chap's got another problem with this optic nerve. There's nothing in anything we've seen so far in the MRI that would make us think of MOG, for example, which does seem to be associated with perineuritis. Those MRI findings are so typical of MS. And as I say, now we know that it's because these are all perivenular lesions that accounts for their distribution, their morphology, and everything about them. I'd rather see the coronal just to see how much involvement there is of the sheath. We know that we have seen optic neuritis in fact, we published one back in when Simon Hickman was doing his research, and we were doing a lot of MRIs post-optic neuritis with David Miller, and we did show that the optic nerve sheath could look abnormal in optic neuritis, and it certainly could have more fluid in it, which makes sense because, as we were saying earlier, if you've got optic neuritis in the orbital part of the optic nerve, the transudate from the edema is going to go into the optic nerve sheath, whereas if it's in the prelaminar optic disc, it's going to go under the retina. So you can certainly get prominence of the optic nerve sheath in MS. It's much easier to see. Have you got the coronals? It's much easier to see.
No, sir. I just have the spinal cord segment, sir. No coronals.
No coronals of the orbits?
No, sir. No, sir.
No.
Only the axial.
No, well, what we can see of it makes us think, well, although this is still more likely to be due to MS, we can perhaps see why he's presenting in an unusual way, because he's got a bit more swelling than we would normally see, and a bit more involvement of the optic nerve sheath than we would normally see. There's a whole discussion to be had over why you get pain in optic neuritis, and why it is usually not as severe as this. But I'm not sure. I'd be more inclined to give him steroids for sure, given this presentation. But I'm not sure whether I would now investigate him for a second pathology.
We did indeed give him, I think, what was the treatment? I think prednisolone. I mean, he was supposed to go for an interview, so 3 days of methylprednisolone. He did even after the second dose probably he deteriorated. So it's a natural course what he's following probably. So the vision was deteriorating even though the first dose of IV methylprednisolone the vision was down. Second dose, yes. Third he showed almost vocal.
I don't like this.
Yeah.
I don't like this for MS.
Yeah. So probably
I don't. Yeah. So one of our criteria for back in 20 years ago, again with Simon Hickman, we published it was a kind of rebuttal of the optic neuritis treatment trial. It was pointing out that some patients do need treatment, not just because they've got tumors or sarcoid, but some cases that are optic neuritis do need treatment. And one of the criteria was if the vision deteriorated, if they responded to steroids and then the vision deteriorated again when the steroid was stopped. This is so unusual for MS. And of course, it's very interesting because why is that? you can't think of any other inflammatory condition, lupus or granuloma or sarcoid. You can't think of any other condition where you could give them a massive dose of steroids for 3 days, stop it abruptly, and they'll just carry on getting better. It's such an unusual feature of MS. So let's have a look here. So he was counting fingers. He then,
After 3 injections, he had some improvement by till 3/60, and in day 14 improved to 624, and day 19 had 612.
oh, he hasn't really got worse again then. He just hasn't improved very much.
So, yeah, so after the 2 doses, probably he did worsen. I mean, because he was here, he said he has to fly out for an interview. So he just has 3 days. So every day we were just seeing him. And probably the 3rd day, he said, okay, fine. It's, you can say a subtle improvement maybe, or just the same. But he did deteriorate, I remember, because I thought it would be the natural course he's going through.
Yeah, well, that would raise my, I probably would do some more investigations with him if that happened, if he deteriorated after after the 3 days. So that was with no oral dose.
No, he deteriorated after the 1st dose, and the 2nd dose remained the same. 3rd day, a subtle improvement, you can say. It was like that.
Oh, okay, so day by day.
Yeah.
But then he had 3 days and stopped.
Yes.
Had nothing, no oral steroids, or
Right.
he carried on oral steroids. Okay, so it was only on that 1st day that he got worse.
Yeah, 1st, 2nd day types.
1st day after the IV. Well, again, it's unusual, but when he comes off steroids altogether, is he right then?
Yes, sir.
Yes. He's perfectly fine without the steroids now.
So when he comes off steroids altogether, he's not deteriorating.
Oh, no.
Yes, sir.
Well, maybe it's just a reflection of the severity of this at the onset. I suppose it's still more likely to be MS.
Now, he had the disease in the left eye long time ago, not on any treatment. The right eye showed whatever it showed, optic neuritis or whatever. Now he's received steroids, he's better. But do you think he's going to have recurrent episodes in view of his underlying disease pathology?
Oh, yes. I mean, I think that our MS doctors wouldn't treat him as a first episode because he's already got the optic neuropathy in the other eye, and he's got a very active looking, I don't know, were there any enhancing lesions in the brain?
But he's got enhancement in the spinal cord, so that's evidence that it's an active
Oh, that was in, yes, that's a T1 with contrast, isn't it?
Yeah.
Oh, there's T2 on there, but
this appears to be T2. Yeah. But what is important is, even if you look at the optic nerve on the right side, it's showing an exuberant extension, exuberant enhancement, I'm sorry.
yeah.
It's there, you see. It's enhancing exuberantly. It's going right across in the orbital segment and it's almost reaching the superior orbital fissure. You know, which is rather unusual for optic neuritis. Gardner neuritis, optic neuritis generally does not have such a long segment of optic nerve involvement.
It's right at the limit of what we'd accept for MS.
Yes. Yeah. And the left optic nerve to me is not normal. There is some amount of optic atrophy. I don't think the left optic nerve is normal. There. That's, I think there's optic atrophy. And I also
that's much easier. The coronals, do try to get the coronals, because the problem with these slices is that the nerve is coming in and out of the slice.
Yes.
Whereas the coronals, you've got the whole cross section of the nerve, so it's much easier to see what's happening in the sheath, in the perioptic space, and in the nerve itself. But it's not surprising that he would have some optic atrophy on that side. But the point is that if he also had other enhancing lesions in the brain, I mean, that's more indication that the MS is active. But I think probably he would go on to first line MS treatment.
Yeah.
But still, you still haven't told us whether you did look for any other cause of the you said his MOG was negative, was it?
MO-MOG was negative.
And both were negative, sir.
CSF oligoclonal bands.
Yeah. And the oligoclonal bands were?
Negative, absent, sir, in CS.
Yeah, but they would ignore that. The MRI appearances are so typical of MS that that would be ignored.
So basically, it's he's being managed by neurology as MS, and that we will update.
Yeah, but I can tell you from the appearance of the MRI, Professor Plant, would this MRI, occur in any other disease other than MS? I mean, looking at the perpendicular lesions arising, perpendicular to the corpus callosum, they're so typically perivenular.
Absolutely. Absolutely.
This is MS. That's MS. There's no, I don't think I've ever seen anything other than MS producing this kind of a picture. Not vasculitis. I mean, this is not what vasculitis would behave like.
No, I agree. We're very fortunate that the appearances in MS are so specific, provided there are enough lesions there. And of course, the thing to remember about the radiologist's criteria is that they are basically set up to avoid false positives.
Yeah.
So they tend to be rather mean, because for research studies, the one thing you don't want for a treatment trial is patients in your MS group who don't have MS. So they tend to set the bar a little bit higher than we do clinically in making a diagnosis. But this patient would fulfills everybody's criteria over and over. So, but I would watch him very carefully to make sure that there wasn't anything unusual about the way this optic neuritis behaves from now on. The most worrying thing, as I say, would be if he deteriorated when he came off steroids altogether. I'd be worried about that, but that didn't happen. So it looks like it's just a very severe, unusual MS optic neuritis.
Yes, it is, because if you look at the visual loss, that is also rather catastrophic for optic neuritis, where you tend to have a 6/24 kind of a vision. This is so that's rather unusual for MS.
It is, but we've seen no perception of light with good recovery. I mean, it's within. It's at the limits, but
it's within the domain of MS. I can understand that. Yeah. I mean, this MRI leaves no doubt. I'm telling you, this MRI leaves no doubt about that.
You have to assume he's got two diseases.
No. I would not look at this.
No, I mean, to suggest that the optic neuritis is not due to MS,
I think Professor Plant, that would be imaginative. That would be very imaginative. I think this is MS. Let's not be over imaginative. What's your take, Professor? Suppose this patient gave you, you would treat him as MS, I'm sure, when you saw this MRI,
I would, but I'd still just be a little bit suspicious. But it would be making two diagnoses to say that that the optic neuritis is due to anything else. I mean, I had a very unfortunate case recently with MS where he didn't come to us because he thought he was just having optic neuritis again, and he had a melanoma in the anterior. What do you call it? An anterior melanoma, which is caused
ciliary body.
Yeah, that's right. He had a ciliary body melanoma, which had caused retinal detachment, and he just kept his routine appointment because he thought he was having optic neuritis again. So you have to, people who have MS are not protected from having other diseases, but
they are not, certainly not. There's one thing unusual in this case. What I noticed was a very low B12 level, 87. I mean, we get to see a lot of low B12s in India because we're vegetarians basically, which is why we get low B12. But this is rather unusual to have a level so low as 87. So I mean, that is what I would look into. I mean, all these relevant antibodies are negative, ANCA, MOG, NMO antibodies are negative. Maybe we could get the antiparietal cell antibodies to have a look at, have a look at the cause of low B12 levels. That's after having excluded some kind of a malnutrition, which we often tend to have when we are vegetarians, where we don't have adequate B12 supplements. Secondly, this MRI picture, sir, you said you spend so much time in neuroradiology. You look at these blobs. This is a beautiful image. These blobs are demyelinating. These blobs are demyelinating. I would not go beyond these blobs. Well, again, sir, as you correctly pointed out, for the optic nerve, you would probably be suspicious that something more sinister may be there. The response to steroids has been dramatic. If you see counting fingers, and it's 6 by 12. Yes, 6 by 12 after the 5th day. There cannot be a more dramatic response to steroids in any other condition other than what we are thinking of. You know, that's my take. I mean, that's my take on this case. You correctly pointed out, sir, that perineuritis tends to be more common with MOG. Yes, it tends to be more common with MOG. We see for every 4 MOGs, we see 1 optic neuritis. When I mean MOG, I mean NMO/MOG. I mean that. In India, NMO/MOG is far more common than optic neuritis of MS. The ratio is 4:1. You know?
Yeah, that's why I don't like the term atypical optic neuritis. It's too...
No, there's nothing atypical. There's nothing atypical. I'm not using the term, you know. I'm not interested in that term. Because
I prefer the term, I prefer to talk about non-MS optic neuritis.
That's perfect. That's perfect. That's perfect.
Because, atypical,
I think that's more sensible and more rational to say non-MS optic neuritis.
One of my missions has been to internationalize optic neuritis research and management.
I don't know what is atypical. I really don't know what is atypical optic neuritis, you know.
Well, as I say, it depends where you are in the world.
Yes, and who's looking at you? Who's treating that optic neuritis? Thank you.
Thank you so much. Thank you. Can you stop sharing your screen? Yeah. Thank you. Dr. Plant, it was an honor to have you here and bless the Neuro-Ophthalmology Society with your wonderful talk. And everybody's enjoyed it. I mean, you can see, Professor Vivek Lal, Dr. Vishali Gupta, and the innumerable messages we've got. It was really a talk, which we were much looking forward to. Thank you so much. And I would like to thank we are fortunate, the society is fortunate to have eminent people like Professor Vivek Lal, Dr. Vishali Gupta. Such a wonderful, such a useful discussion we could have both on the neurological and the retinal side. It just made everything so cohesive and went along with the flow. Thank you so much. And yes, I would like to thank my senior resident, Dr. Shagun. We had a wonderful discussion on the case, the way she presented and whatever she's collected. She's always been there, since a year or more than a year and managing these cases, and she's doing it very well. Thank you so much once again for being a part of Chandigarh Ophthalmology Society for the webinar.
Thank you.
Professor Plant, happy grandparenting. Happy grandparenting.
Yes, it's been a real pleasure. I really have enjoyed this very much. Of course, it's a pity we can't all, give each other a hug.
Oh gosh, we could. Well, this pandemic has to end someday.
And you have to come back to Chandigarh now.
We had decided that, but I really don't see any. There's no silver lining at the moment. At the end of the tunnel,
Maybe 1 year, next year.
There's a second wave already on in Europe, so it probably have to postpone it.
It will end sometime.
Yeah.
I had a festival planned, as you know, in March.
Yes.
Which was postponed for a year, but it looks as though it's probably going to have to be online.
Yes.
Even next March, I don't see people moving around the world.
Yeah.
But one thing I will say, we tried what we used to call telemedicine.
Yeah.
Back in the 20th century, we tried telemedicine, and it was always rubbish. It was so expensive. it was so expensive, and it was just rubbish. It would never work properly. But now anyone, you know, I mean, I know I'm not, obviously it takes a little while to set up these things, and they have to run smoothly, but the technology is amazing, really. We even have bands now playing on Zoom, all in their own homes, playing music together on Zoom. Things like this.
Yeah.
But, so it's what we have to do. It's what we have to put up with for now.
Celebrating birthdays on Zoom, one person cutting the cake and everybody clapping from.
Oh yes, yes. It somehow doesn't work with a bottle of wine, though. It really doesn't. Not the same.
We will end it with a positive note. Hopefully we can see each other in person soon.
Yeah.
Thank you so much.
Yes, my only condition of coming to India is that Professor Lal helps me get the visa.
Yeah.
Oh, it'll reach your house. That's for sure. You don't have to move on. It'll be
I
there.
tell you, getting a visa for India, once I discovered I needed one, it's terrible, really terrible.
Nightmare. Indian.
Right. You won't go through that nightmare again. That's for sure.
When I first time I came, I ended up in the High Commission, being handed my visa on a silver platter by the secretary to the High Commissioner, sitting in leather chairs. I couldn't believe it. I walked past this queue going all the way down the Strand and was shown up to this. I don't know what you told them, Professor Lal, but whatever it was, I don't think it was entirely the truth.
No, but we do that again for you. That's for sure.
Oh, please. I've also been invited to a lot of Indian weddings. I've never been able to spare the time to come.
Well, you must.
But now I'm retired. I think they're all married now. I think all of my fellows are married.
No, there'll be still few waiting for you. That's for sure. Bye.
Thank you so
Bye
much.
now.
Thank you.
Bye. Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Bye.